So as the title says, it's pediatric submacular hemorrhage, and the question is to wait or to inject CPA. So a 13-year-old boy presented with acute painful drop of vision after blunt trauma to his right eye. There is no past or medical history. His visual acuity in the right eye was counting finger 50 centimeter with traumatic midriasis, and the IOP was 37 with hyphema in the anterior segment, and the fundus was hazy due to vitreous hemorrhage. The left eye was unremarkable. This was his OCT, showed submacular hemorrhage involving the fovea in multiple cuts, as you can see here. So I consulted many. Some say to intervene, some say to wait, but the family insisted that we should intervene. So we went for vitrectomy. We can see here the traumatic midriasis and the hyphema in the anterior chamber. The lens was clear, of course, he is a child. We went for 23 gauge vitrectomy. First, I started with core vitrectomy, but the view was very hazy. I thought this is because of the vitreous hemorrhage. So I trying to aspirate the vitreous and the hemorrhage, but the media was not clearing up. So I was thinking, what's wrong with this? I remember that the kid has hyphema, but I thought that this was localized inferiorly, but there was dispersed hyphema, so I opened a paracentesis and I did an AC wash to clear up the media, and it worked. Actually, while irrigating the anterior chamber, we can see here the red reflex becoming bright. So now I can continue my vitrectomy now safely and finishing the vitreous and vitreous hemorrhage before coming to the next step. Of course, I have to make sure that there is complete PVD in this child. As we know, the vitreous is sticky in the children. At my institute, there was no experience in injecting TPA or preparing the TPA. This was the first case in my institute where we need to prepare the TPA. So now I'm going with the 41 gauge needle, injecting the TPA submacular. And as we can see here, while injecting, there is macular detachment. It's increasing. I was lucky that the hemorrhage amount was not that large, so I did not need large amounts, but I decided to go for another injection with the 41 gauge needle of TPA and finishing up with a small air bubble, slowly injecting it to avoid the occurrence of macular hole. The air bubble helps in displacing the hemorrhage, submacular hemorrhage, of course, as you can see here. So now I have the macular detachment and the bubble subretinal. And we finish up the case with partial air fluid exchange and asking the patient to have a semi-sitting position or sitting position for the first few days. There's no need to laser, of course, the site of injection of the 41 gauge needle. And afterwards, this was his OCT 2 weeks later with a visual acuity of 0.7. And luckily, the source of the hemorrhage was a choroidal rupture. We can see it here. It was away from the fovea, and the child was happy, his mother was happy, and of course I was happy. And this was his ultra-wide field. We can see the displacement of the hemorrhage inferiorly below the inferior arcade. It's very evident in the infrared image here, and thank you so much.